Now, tough questions from the audience, or not.
I'll start. How do you think, as a community, we can get the information out to the population about the palliative care? How?
Well, because I think one of the first places that you would probably think about is the African American church. The church is a symbolic central hub of the African American community. And I know here in Indianapolis, Eastern Star Church has been a huge contributor to outreach in the community. And I think that giving this information to a mouthpiece that can reach a large number of people, giving them, making out workshops. In fact, Eastern Star Church had a workshop about palliative and end-of-life care. It was a Saturday workshop for people to come in and learn about this information for free, and they provided food. And I think that word of mouth, literature shows that word of mouth is huge for informing people about end-of-life care. I think that within the African American community, that we are people, we are oral people, and so we share a lot of information orally. But with the younger generation coming up, I do believe that technology can be used in the future to improve communication. Because the baby boomers are getting older, my generation, the millennials, are going to be the ones that are going to be making decisions for the older population. And how does my generation communicate? We communicate via social media, texting, and so I think that maybe an end-of-life app, I don't know, could be a way to communicate this information to everybody.
So I'm curious, I don't know how much time you've given thought to the findings related to males in your studies. That's, my area is men. And their outcomes are poor, as they often are. What do you think would be the direction to take any sort of action with regard to improving communication with men? I know that's so much, but
I think that, and you can disagree with me, but I think that the African American community is a matriarchal.
Exactly what I was thinking. Yes, I wondered if you were going to.
Yeah, I think that our communities are driven by females, and so because females often have better communication skills than males do. Men have historically been considered stoic. They don't like talking about their health. They don't like going to the hospital. And one study found that women who lost their husband fared very well after the husband died. But conversely, men did not fare well at all. In fact, their mortality rate was high for the first 10 years after their wife's death. Now, why is that? Well, some people might say that the woman was taking care of the husband, and so when she died, his mortality rate went up. So I think that improving communication with females in the African American community will improve information flow for the entire community.
For the record, I agree.
Okay. Anybody else?
Esther, do they say anything specific that the healthcare team did to really influence their decisions? I mean, I know you said the more information they had, the easier it was for them to make a decision, but did they give specific examples of what really worked for them?
Yes, they talked about the healthcare providers that were deliberate in their actions. Several people talked about the deliberateness of calling me when I did not call them. Making sure that I was completely informed on a regular basis. It wasn't spotty communication, it was continuous communication. Showing that they cared was a huge piece of the communication process, even though that's relationship building. One person talked about a healthcare provider that prayed with her and her family. Another talked about how the healthcare provider provided a warm blanket and was willing to re-warm food for the decedent. And so being personable was huge for them in their communication. Just to give an example of how healthcare providers were able to improve and influence the communication as well as the relationship that they were building with the family members. Just a small example.
Okay, follow-up question. So now that you have the perspective of the family, and the goal is to improve the end-of-life communication, what next for improving it on the providers? And what do you foresee needs to happen?
Well, there is literature that shows that communication can be improved among healthcare providers. We know that that can be improved, and I know there's research being done here, OncoTalk, among oncologists to improve their communication at end of life. And so I think that reaching the healthcare provider in their training is key, and then having that training consistent. It doesn't stop with a medical degree. It continues on into practice. So I think that improving the amount of training as far as end-of-life care and end-of-life communication is necessary, because many medical programs have a very small amount of time devoted to end-of-life care and communication with patients and families. So I think that that is a way to improve the skill set that physicians have at the end of life. Start when they are young in their discipline, and continue to have continuing education, and make it mandatory that they show that they are continuing to educate themselves beyond medical school.
So as they're moving it into the nursing ramp, what can we do as in the academic setting and clinical setting to put nurses at the level of appropriate training and as members of the healthcare team to support this?
I think that, when I was coming through nursing school here in the accelerator program, I remember that I went through a simulation process, and it was only one time, and I think that's unfortunate that it was only a one-time experience where we had an end-of-life scenario with the sim man in the sim lab. And so we had to go through and make decisions for the care that the sim man received. Now, I can recall I made poor decisions when I went through the process, and there was really no follow-up education with that one scenario. So I think that, again, there needs to be consistent communication and training, and I think that it should be integrated not as a special event, but it needs to be integrated as we go through critical care, we go through med surg, so those are important aspects of care. And because end-of-life care is a new field, I think with time, I mean, it's only been around for 30 years or so. With time, it's going to be more prevalent, especially as the baby boomers begin to age and their death rate increases. I think that baby boomers have huge influence, I'm noticing, on the way that things happen in our society. So I think that to care for them, it's going to be important to make education about end-of-life care not a special event, but a mainstay in nursing education, as well as medical school curriculum.
I promise this is the last question for me. So following up on Sharon's question, and me coming from my community health perspective in terms of what nurses can do, I'm sure that when you talk to the family members who had high decisional regret for the decisions that they made, what would you suggest nurses could do to support those survivors, as they are dealing with these high levels of conflict, even sometimes 6 months after?
Yeah, it actually lasts for some more than 6 months.
Yeah.
In speaking with the people in my study, and these were people that were 2 to 6 months post the death, and those that had regret and they were not happy about the way things happened. I suggested bereavement counseling for them in order to help their bereavement. But I think that nurses can step in the bereavement. St. Francis and many other palliative care programs have resources in place in order to be able to support these people. So I think that hospice and palliative care often are not used because people don't know about them, especially among African Americans. There was a study done that asked them why they did not use hospice, and they say, well, we simply didn't know about it. And so I think that with knowledge of the resources that are available, and in fact, in my study, several people talked about how they did not know about resources. One woman gave suggestions as to how we could improve the knowledge about these resources. She said, maybe you can create a DVD or something like that to give to people who are entering the end-of-life care process. Give them this DVD, allow them to look at it, and then allow them to come back and talk to you, to ask questions about the options that are available. So she wanted to know about hospices in the community. She wanted to know about the resources as far as what entities can come into the house to help care for these deceased, as well as after her I think it was her husband died, she was upset about it, but she also wanted to know, she wanted to talk about it. And many of these people this was a therapeutic process for them. Talking about the loved one's death helped them in their bereavement process. So maybe there could be I know that Eskenazi at one point had No One Dies Alone program. So maybe it could be a program such as, in addition to No One Dies Alone, No One Lives Alone After the Death. So there could be resources for people to come out and talk and spend time with bereaved family members, and nurses could fill that role.
We have time for one more question.
To the right.
One open.
Esther, I hope this is appropriate, but I was just looking at this beautiful picture of your aunt. And did this study, I could place you inside this study in a lot of ways. It's like you could have been interviewed. Did this study help you to reflect on that memory of your aunt, or how you could have maybe done things different, or if you would have had the knowledge, how maybe you could have helped more in the
Definitely.
process?
I definitely think that if I personally could do it again, I would have mentioned hospice sooner. I breathed hospice a little bit, and we just were not as a family in a place, and we didn't know enough about hospice and palliative care to be able to accept it when she was dying. And so my aunt was about my height. She was a little shorter than me when she passed away. She was maybe 113, 14 pounds. She was very skinny, and she died with someone giving her CPR. And so it was, I think my mother can attest, looking back, I think hindsight is always 20/20. And I remember a conversation that I had with my mom after the fact, I think it was maybe 3 months later, and she said, Esther, we didn't do that right. We didn't do it. We didn't make the right decisions for her care. And so this study is literally to me, this research is living and breathing, and this is a living and breathing example of what we could have done differently. We should have had better communication. She should not have received chemotherapy and radiation. She should have been likely on hospice when she was first diagnosed, because she was diagnosed with stage 4 lung cancer. So she needed comfort-focused care, and we didn't know enough about cancer or the treatment options in order to make the appropriate decisions for her care. Did that answer?
Yes.
Okay. That's amazing. That's great. Thank you, Esther. That was one of many presentations you'll give and articles you'll publish down the road. But thank you, everybody, for coming. I do know where to go.
I was thinking I could take them down to the student lounge, since most people are not down